I think we'll get started. First of all, I just want to thank everybody for joining us today on World Malaria Day. And for those of you who are joining online, you could feel free to log on to the chat to introduce yourself if you'd like. And also, as we go along, if you have any questions, feel free to put them in the chat. So we won't be able to answer all the questions, but we'll be looking at those to pick out a few that we will share with our panelists and other discussants. This webinar is being recorded. We're also pleased to offer simultaneous interpretation in French today, as well as closed captioning. So if you want to select your preferred language, you can click on the globe icon at the bottom of the screen. And when you do so, you'll see an option to choose English or French channels and to mute the original audio if it's distracting you from hearing your language of choice. If you need any technical support, please contact my colleagues in the chat box. In addition, if you'd like to select whether or not you would like to read captions during the session, you'll see these captions automatically. But if not, you can select them by clicking on the icon with the two C's. And if you wish to hide the captions later, please select the same icon again and select Hide the Subtitle from the menu that appears. These captions are generated using automatic feature in Zoom, so there may occasionally be some errors. And on the Zoom platform, captions are only available in English at this time. So again, feel free to use the chat to comment and to ask any questions at any time. We'll have ample time for discussion and try to respond to as many questions as we can. So it's my pleasure today, first of all, to kick this off, to introduce my good friend and colleague, Ade Adetosoye from Management Sciences for Health. Ade is the Vice President and Program Delivery Group at Management Sciences for Health. So Ade, I'll turn it over to you.
Thank you very much, Bernard. And good morning, good afternoon, good evening to all of our colleagues tuning in from across the globe today. I see those numbers going up there. Welcome. I am thrilled to be providing these opening remarks, and I'm really excited about the conversation that we're going to get into shortly with our highly esteemed panel of malaria control experts on this day. For over 30 years, MSH, alongside countless dedicated organizations and individuals, has stood at the front lines of the battle against malaria. For example, today, MSH is implementing the flagship President's Malaria Initiative for States project in Nigeria, helping to coordinate control efforts in partnership with the National Malaria Elimination Program. In over 40 countries, we've witnessed both remarkable victories and a few setbacks. The road has certainly grown steeper in recent years. We had the COVID pandemic. We had devastating impacts of climate change, conflict, and economic uncertainty that have affected our progress. Yet, amidst these challenges, a powerful beacon of hope shines through. Today, the future looks really bright. We stand on the brink of transformative breakthroughs. We are currently witnessing the rollout of not one, but two promising malaria vaccines, which offers us a glimpse into a future where this disease no longer claims lives with such heartbreaking regularity. Innovations in insecticide-treated nets, diagnostics, and treatments continue to evolve, enhancing our ability to fight malaria effectively. Donors have kept their commitments too. We've had responses from multilateral agencies like the Global Fund, with its investments of almost $18 billion, the US government's President's Malaria Initiative, having invested over $9 billion. These are all vital lifelines in our collective effort. The unwavering commitment fuels progress that we see on the ground. Fewer people are suffering and dying from malaria because countries have better data systems that have been targeted by these funding to guide their strategies. No longer are we shooting in the dark, no longer are we fighting blind. Using reliable data informs our actions. Using reliable data helps measure our impact and guides our future directions. Recognizing this, MSH, for example, has strategically elevated data use as a tool to demonstrate our impact, including this as a pillar in our 2023 to 2030 strategy. Personally, I have lived in malaria endemic countries, and I have seen people suffer endlessly through cycles of malaria transmission, morbidity, and unfortunate mortality in cases. This is why I'm filled with anticipation today about this exciting webinar. We've lined this up to delve into this important matter. What is the relationship between data and action? We must pay attention to the data. We must look at how we use data to make decisions and how we use data to act. Where are we succeeding? Where are the opportunities slipping through our fingers, and how can we collectively seize them back? What innovations excite us, offering lessons to adapt across communities around the world? And most importantly, I would say, let's let the data-driven stories we hear today from this panel ignite within us, wherever we work, a renewed sense of hope. I'm convinced we will win this fight against malaria, and that we will live in a world where no one dies from a mosquito bite. I'm going to stop here so we can get this exciting show on the road. Thank you, and over to you.
Thanks so much for that, Ade, to set off and get us started this morning. First of all, I should introduce myself. I just kind of assumed that I know everybody and everybody knows me, but I'm Bernard Nolan. I'm the director of the Eck Institute for Global Health here at the University of Notre Dame, and previously I was the deputy coordinator for the President's Malaria Initiative for the first 11 years. So, and as someone who's spent my whole career working in malaria, I know that many, if not all of you in this call have had family members or friends who've died or been adversely affected by malaria. And I can tell you that in the year 2000, when there were 1 million kids in Africa, estimated million kids who were dying of malaria, I never, frankly, thought we would be where we are today in a positive way, but we also recognize how much further we have to go. And thanks to all of you for being involved in the fight against malaria. So, real pleasure to introduce our great group of panelists today. Jean-Philbert Nsegimana is the Chief Digital Health Advisor for the Africa CDC. Joangeline Colombo is a Senior Specialist for Public Health and Monitoring Evaluation at the Global Fund. Dr. Leah Flore is the Senior Advisor and Monitoring Evaluation Expert with the U.S. President's Malaria Initiative. And Dr. Inibasi Inglas is the Deputy Chief of Party for the President's Malaria Initiative for the PMI for States project, which Management Sciences for Health leads in Nigeria. So I'll start off with you, Jean-Philbert. Your work with the Africa CDC gives you a unique perspective on the main challenges countries face with their public health data systems. Could you give us 2 or 3 examples of the common issues and your suggested solutions?
Yeah, absolutely. Thanks, Bernard, and great being here. Thanks for the invitation. I like how you teed this up by showing really the connection with how malaria affects all of us in a personal way. On myself, malaria was my second near-death experience when I was 20. I almost died of it. And the first one having been measles when I was 5. So when I talk about this, I don't see myself as an expert in malaria control, but I realize how what we are doing at Africa CDC, promoting the better use of data for evidence, how that really supports the fight against malaria and leads to saving lives. So I've got 3 examples that I would like to use to discuss the role of data and the kind of challenges that we are facing, as well as the opportunities. In terms of challenges, we still have a bit of data fragmentation and lack of interoperability that hinder comprehensive analysis and decision-making across the continent. An example I can give, and this is something you will find across the country. Today, I'm calling in from Kenya and Nairobi, and malaria data here in this country is stored in different organizations that have different roles and contribution in fighting malaria. The Ministry of Health keeps a platform and a database. NGOs such as AMREF Health Africa, also very involved in fighting malaria and collecting a lot of data. Research institutions like KEMRI, supported by Wellcome Trust, they all maintain different databases, and everyone understands how that robs us of an opportunity to have comprehensive database that can improve the quality of evidence and the decisions that are made to fight malaria. So there is a need to keep pushing the needle when it comes to adopting common data standards and interoperable systems, not just in Kenya, but in all the African countries, to enable seamless integration and facilitate evidence-based decision-making to combat malaria effectively across our countries and our member states. An opportunity, a unique opportunity that we have is through community engagement, participatory surveillance, and bottom-up data collection approaches. And I can give an example from Uganda, where through an initiative by the government, community health workers were equipped with mobile phones, and they go around in communities collecting and reporting data about malaria cases in real time. And this approach does not only harness the power of data, but also empowers local communities to take an active role in monitoring and responding to malaria outbreaks. And one thing that, like, mobile is the most distributed type of infrastructure available in Africa. So that allows really to engage communities in such bottom-up data collection efforts and provides more accurate and inclusive picture of the malaria situation in Uganda and many other countries where such targeted interventions have been implemented. Finally, I want to highlight the importance of cross-sector collaboration, especially public and private partnerships and data sharing agreements, and how they can drive solutions and evidence-based interventions. The example I want to use today is a project in Mozambique, where collaboration between the National Malaria Control Program, Vodacom, which is the leading telecom operator, and a tech startup called Benz Bio has yielded a really promising result by combining anonymized mobile phone data with malaria case reports. They developed a predictive model that can help forecast malaria hotspots. So these kind of innovative data solution made possible through cross-sector partnerships and data sharing agreements enables proactive deployment of resources and targeted interventions, such as insecticide spraying or malaria or distribution of treated nets. So those are the few points that I wanted to use this afternoon to share what is being done, harnessing the technology in the fight against malaria on the continent. But I want just to echo the points made by Dr. Ade on the great news on the availability of the vaccine and the promises and the hopes that this research breakthrough has brought on the continent. And we look forward to also use technology to track the deployment, the distribution, the effectiveness of the malaria vaccine when it starts getting rolled out at scale on the continent. Thank you.
Thanks, Jean-Philbert. I appreciate that. So we'll have some remarks from our next panelist, Joangeline Colombo from the Global Fund. So Joangeline, with an estimated $3.8 billion funding gap, malaria programs need to find efficiencies. How do you and your colleagues at the Global Fund use data coming out of these programs to make program funding decisions?
Thanks, Professor, for the question. Good afternoon, good morning, everyone. So I will go ahead and use our Nigeria malaria grants as an example of what myself and my colleagues at the Global Fund do. As you can imagine, demands in Nigeria are significant. However, over the years, the partnership has gotten very good at understanding cost drivers and calibrating how things are done to stretch the dollar without compromising program quality. So I'll highlight 3 investment areas. First up is seasonal malaria chemoprevention, SMC. In 2019, the Global Fund Malaria Grants supported approximately 400,000 children under 5 for SMC. This number went up by 2021 to 13 million children annually. And currently the target for the next 3 years is 18 million children per year in the 10 states that we support SMC. It is an expensive undertaking. However, since 2021, by using population estimates, microplanning data, campaign results, and expenditure data, we have been able to expand programmatic coverage and provide adequate financing for SMC in these 10 eligible states. So we do continuous analysis of the data, which enables us to we've been able to budget between $1.35 to $1.80, depending on the state per child for the operational costs of the four cycles annually. This is in comparison with what we regularly see our country budgeting about $3 per child for operational costs. So our periodic close monitoring of pragmatic and financial data actually frees up resources from our budgets, which are usually reinvested to address other emerging pragmatic needs to accelerate the impact. One thing that we've done, and other speakers have mentioned, starting from 2022 for our SMC campaign, we started using technology. We did that with our ITN mass campaigns in 2018, and the use of technology has significantly improved how we see and understand and use data for decision-making on a daily basis during campaigns or during preparation. One thing that we are very excited, by using technology, it has allowed us to introduce SMC cohort tracking. And this for us has been absolutely a game changer for our implementation. We are learning so much on how we do things. So that's the first investment area. The second investment area is the mass distribution of our ITNs, insecticide-treated nets. We know they're expensive. Again, we are very meticulous in budgeting and implementation monitoring. In 2017, for example, our grants were budgeting about $2 per net for operational costs of mass campaigns. And at that time, we decided, we really need to understand, the details. Why are we spending $2 per net? And so we started doing this detailed analysis. And for the current grant cycle, which is 2024-2026, we're budgeting about 50 cents per net for operational costs, with 10 cents less for some of the campaigns that we will have where we will integrate SMC and ITN. So, we've also introduced innovation like using GIS, which has been very helpful in getting maps and identifying missed communities. And lastly, quickly, another example from the case management, we ensure that malaria commodities quantification and supportive activities are evidence-based and are informed by the grant data. So for example, we have having robust supply plans that undergo comprehensive reviews on quarterly basis using both service and consumption data is very key. We also have LMIS, HMIS triangulation exercise happening biannually. Also second, we supplying case management capabilities by reviewing caseloads and also looking at the seasonality. This helps us to anticipate the level of financing needed vis-a-vis supply chain pipeline. So these are some of the examples that Global Fund uses both programmatic and financial data to make decisions at grant level. Obviously, when you have a informed, evidence-informed budget, you closely track your expenditures. Automatically, this unlocks resources which can be used to expand programmatic coverage to accelerate the impact. Thank you.
Yeah, thanks, JoAngeline. So now we'll turn to Dr. Leah Flory with the President's Malaria Initiative. So, Leah, can you tell us briefly how the President's Malaria Initiative is supporting national malaria programs, and the broader malaria community to use data for informed decision making?
Yes, thank you, Bernard, and thank you to MSH for the invitation to speak today. Excited to be here on World Malaria Day with you all. Yeah, so PMI, I'm sure, Bernard, you could give a more comprehensive history of PMI than I can to this group, but PMI has been supporting national malaria programs since 2006 in their efforts largely to strengthen systems for malaria control, prevention, and elimination. And I think one of the unique things about malaria is that it's one of these diseases that we really don't want to be trying to attack in a siloed way, right? It's major cause of morbidity, mortality in many of the communities that we work and support, and it's very important that we approach our efforts in an integrated systemic way. So that's the approach that PMI has taken from the beginning, trying to work very integrally with our partner country governments to focus on system strengthening. So that is in the data space as well as in the other areas that have been mentioned by colleagues, such as supply chain strengthening and other things as well. So our approach has always been to work very closely hand in hand with national malaria control programs. And we work with many partners in the data space. Traditionally, for many years, we've been working with Measure Evaluation, that was followed on by Measure Malaria, and now CHISU as central level partners, but so many others at country level. We've got, I think, a lot of folks on the phone from our partners in Nigeria and elsewhere. I think there are lots of activities that we work on, such as surveillance assessments of national systems using the toolkit that was developed by WHO and many partners worked on, trying to get a sense of the level of functioning of the surveillance systems in which areas could be strengthened. Support technical working groups, development of national strategic plans and malaria program reviews, efforts to bring together all of these malaria data and work on stratification and subnational tailoring, which has become a huge focus in recent years to try and make the best use of our limited resources. At the central level, there are many other activities that our partners help work on, such as, in some cases, automating malaria bulletins to remove some of the, I think what is, traditionally been bringing data together in maybe not so advanced ways, and being able now to take advantage of our technologies to automate these processes. I think there's been a huge focus also on data repositories, again, to try and triangulate all of these various data sources that are necessary to understand what's going on in the complexity that is malaria. We support lots of efforts to also focus on improving data quality, and that can range from things like DQAs, data quality assessments, as well as supporting lots of training and supervision of health workers that are actually inputting the data into the system, which is really the key, right? We have to focus on all levels of the system if we want to improve the data quality. And I think there are some great examples already presented about getting the data from the community level, collecting it with digital devices or other things so that it can be of good quality up the chain. And maybe just to mention that I think over the time that PMI has been active in this space, the breadth and scope of our surveillance, monitoring, and evaluation activities has changed quite a bit. And that over the past decade, we've seen a huge shift in how those data are coming into the system, with the transition to really rolling out DHIS2 platforms. And that has meant that these data quality investments have become so essential. And I think it's also brought new personnel needs. So having, I think, those folks who are experts in some of the issues that our first speaker mentioned about data fragmentation, interoperability of these systems, it becomes really important. So we have all the data we need in one place that we can bring it together and use that for our decision making. I wanted to mention just a few examples, speaking to the personnel needs. I think along the way in the past few years, PMI really realized the importance of these shifts in investing in this, and we hired data specialists across our partner countries in order to support some of these new challenges and provide malaria-specific support really focused on the improved quality and use of the routine data that's available. And one example from one of the data specialists that we work with in Zimbabwe, Busisani Dube, he analyzed, just an example, some surprising patterns of increased malaria incidents that they were seeing in Zimbabwe, as well as increased malaria case fatality, which wasn't a trend they were used to seeing, and triangulated these data coming in from DHIS2, the case data, with climate data, with some of the COVID-19 data, because have to understand what's going on in the bigger system and febrile cases. Triangulated supply chain data, human resources, brought this all together and tried to figure out what was actually going on driving these increases in cases. In another example from Mozambique, we have another data specialist who helped the National Malaria Program also try and figure out what was going on in a trend of increased malaria deaths in Niassa province. And again, through this triangulation, bringing the data together, was able to figure out that there was an issue of stockouts in a specific health facility area that was really contributing. And then I just want to mention that PMI works very closely hand in hand in global fora with other partners to look at all of the public sources of data, to try and figure out how we can best use our resources, because the resources are global and we want to be working collaboratively. I think collaboration is so important in this space. So we are part of these global efforts to use the DA to fund and use the data coming out of demographic health surveys, from malaria indicator surveys, to share all of the data being collected by our partner countries and our partners to help with the models that WHO puts together for the World Malaria Report, and to collect and share insecticide resistance data and therapeutic efficacy data as well, so that all of the partners that are working together have the best information possible for these challenging decisions that we have to make about our limited resources. Thank you.
Thanks, Leah. Actually, you highlighted the importance of collaboration around these issues. So I'm just curious, since we're fortunate to have both Joangeline from the Global Fund and you from the President's Malaria Initiative and Jean-Philippe Bell from this Africa CDC. So if I'm the malaria program manager in a country and I have different data needs and different data sources, but I also have some important folks who are helping to provide technical and financial support for that. Can you say a little bit about how the Global Fund and PMI, this is to all of you, and CDC Africa collaborate on that? I mean, what actually happens at the country level and at the, these international settings?
Who wants to start? I'm happy to start and pass it off. So I think many people know the last round of Global Fund applications has recently maybe you should speak to that, Angeline, but PMI, our PMI staff in countries, our colleagues work hand in hand very closely to make sure that we're sharing all of the information that PMI has about our annual financial planning with countries as they go through the grant making and application process. I think that there can be some challenges with having these varied cycles of funding, right? It's not straightforward when Global Fund has 3-year cycles and PMI has annual cycles, but we have a lot of experience in this space. And we definitely, I think, have teams in country that work hand in hand to avoid any sort of duplication of effort. And then I'd say in the global space, there is the Rollback Malaria or End Malaria Partnership Monitoring Evaluation Working Group, which is a forum for all partners and donors and implementers to come together and coordinate activities. I think this effort to really have data-based information to go into this last round of Global Fund grants, so the stratification exercises and subnational tailoring was meant to be an opportunity, I think, for everyone to come together, share their data, and put together sort of a map of needs and perhaps ideal intervention, what's the right word I'm looking for, distributions across countries to make the best use of limited resources. But over to you, Angeline, maybe you can add things.
Thanks, Dr. Leah. So maybe I'll add to the list. We do collaborate in different ways. We, for example, PMI operational planning, we usually attend those meetings, those discussions, and it gives us an opportunity to do the checks and balances on what exactly they're doing vis-a-vis what the Global Fund grants are supporting. But at the same time, there are certain activities that over the years we have been gladly co-financing, from training of microscopists, across the 36+1 states in Nigeria, to supporting field work, for example, for the Global Fund for the malaria indicator survey, while PMI, getting the technical implementer for that. We also have routine check-ins, when we go for missions for us, because we are based in Geneva, but also we have quarterly check-ins and random check-ins at any time. I think, and lastly, I just want to highlight, which I think is extremely important when it comes to collaboration, the Nigeria Malaria Elimination Program. They have a very good governance and coordination framework. So through those fora, whether it's a subcommittee on IVM or case management, it gives us opportunities, not just Global Fund and PMI, but all the partners that are part of the Nigeria malaria community, to have these very relevant discussions. Thank you. Over to you, Jean.
Well, thank you. I may not have the full scope of what my colleagues in the infectious disease department are doing with PMI and Global Fund. I know that we are working, especially with the Global Fund, on tackling the question of connectivity on the continent, because for people to be able to collect data, especially in the deep rural areas, they need to be connected. So we've been working with the teams at the Global Fund, trying to join our forces as part of an initiative that we have at Africa CDC called Health Connect Africa. We are aiming at connecting 100,000 health facilities to the internet and 2 million community health workers. So we've been discussing with our colleagues, because part of the support that the Global Fund gives to member states is in the area of digitalization, and a bit of that goes either on powering health facilities, or even extending connectivity to some of the places that are unserved, as part of the support to the major programs that the Global Fund supports in our member states. So that collaboration is in place and is growing, and we are working to deepen that. With regard to PMI, maybe Dr. Leah, you may know whether there are any colleagues. Big institutions are like that. Sometimes you may not have the full breadth of what's who's speaking to, but I can attest to the conversations that we're having with the Global Fund in this area.
Yeah, thanks to all of you. I'm also just curious. So I think sometimes people who don't work directly in malaria may question why malaria, for example, Leah, you mentioned malaria indicator surveys, or why can't the Global Fund and PMI and others just use the routine health information systems? What is there that's specific about malaria that wouldn't allow that to happen? And then secondly, what data do you get from the health information system, and what's the quality of that data? I was wondering what you say to folks who say, though, malaria is kind of going on its own and they're not actually involved in strengthening the overall systems. That's to anyone who would like to comment.
I'm happy to start again, but I mean, I think that's a great question, Bernard. I think we deal with this all the time because surveys are very expensive, right? They're resource intensive activities. And I think traditionally, you know, some of the indicators we're looking to collect through those surveys are intervention coverage based, right? I mean, many of our interventions that we're funding right now have not been around for decades and decades, at least not at scale that we've seen a drastic shift over the past 2 decades in the coverage of our major interventions, right? And we wanted to track that and monitor that. And you can't really collect that intervention data through routine systems. So I think that was, you know, a major driver for collecting survey data. And then at some point in probably 10, 15 years ago, there was the addition of biomarker testing to these surveys to look for parasitemia and try and track, you know, what the prevalence was in children under 5. I think there's a lot of discussion going on about whether or not we continue to do that, or should we be making best use of imperfect data that are coming in through the routine systems. Is the, you know, anyway, what are our actual needs in the survey space, I think are questions that we're grappling with right now as we have limited resources and the surveys are quite expensive. In the routine data space, I think, again, that has changed so drastically, right? As more and more facilities have come online, you've got a changing denominator of the data being reported. As you have increased investments at the community level to have community health workers reporting data into the system, that changes your denominator again, right? So how do you interpret the trends that have taken, that are coming into the routine data over the past 10 years when the totality sort of the picture of data coming in have changed quite a bit. So, I mean, I think as that starts to level off, as we reach sort of saturation with the data sources coming in, the level of reporting, then maybe those trends become easier to interpret. But I think we have lots of strategies to deal with that as well. We have partners that model the data. We have applications on DHIS2 to look at some of these data quality concerns. So I think it's something we're monitoring, but I think we're not quite to the point of having a full picture from all of the communities at risk of malaria in our routine system yet. I'm sure others have things they want to add.
Yeah, I don't know if Joangeline or Jean, if you have any comments on, again, this issue of malaria data needs and what can we get from the routine systems and what will we need to have special. So for example, as we all know, ITN delivery, SMC, some of the malaria specific interventions are not done routinely through routine systems. It involves people on the other groups like Management Sciences for Health and other partners at the country level to assist with that. So what do you say to those who don't work in the malaria space on, frankly, sometimes criticism that malaria, I think it's a wrong viewpoint, that malaria somehow is siloed?
Well, I can give a response based on first principles. I think the problem of siloed information systems versus health information systems that like DHIS2 that are more horizontal is a problem that is not just with malaria but also with other programs, vertical programs. I think there is an appreciation that a generic tool may not be good enough for a specific program, but there is also an understanding that there should be sort of a plug and play between the vertical programs with the health information systems, so that the policymakers have one way of getting access to the information, and all those databases share a base, the same building blocks. Things like the facility master list, the provider master list, the taxonomy in terms of medications and so on and so forth. So I think the criticism about siloed programs is there because there is no connective tissue between those silos and the foundations. So I think the kind of ideal architecture that we are trying to push and discussing with member states is, how do you sort of set up what a country could, a Minister of Health could call like a ministry app store? Because there are so many vertical programs, malaria being one. Even within the malaria program, there could be many apps. But if there is a common app store that everything is plugged in, and then beneath that, there is perhaps some kind of data lake or data repository that allows all this information to be linked, I think that would be a good way of optimizing the resources that are invested in putting up these information systems. But to be more specific than that, I think we would need a case study from a specific country, and this is where Angelique can perhaps come in.
I don't know if I can I can answer what you just asked me, but I just wanted to say that indeed some of malaria data is siloed. You mentioned campaign data. There's resistance surveillance data. However, I think by large, malaria data cannot be completely siloed, as it is the most reported disease in most countries that still have malaria. I think what our challenge actually is to ensure that malaria is included in all systems in which it is relevant. So pandemic preparedness, right? Which often it's focused on case-based surveillance rather than something like acute febrile illness surveillance. That could mean lost opportunity for setting up systems that can better detect all diseases of epidemic or pandemic potential. Therefore, I do think that just because some data is very disease specific, and in some cases has to be collected in a siloed manner, it does not necessarily make it a bad thing or less worthy. Sometimes that's just a fact. But of course, there is a need for a strong emphasis on leveraging all opportunities for integration, because integrated approaches will have wider health impact and will achieve more efficiency by doing that. Over.
Yeah, thanks. There's several comments in the chat on the push towards malaria elimination, which I think we all are behind. And actually, we've seen even over the past few years, a few countries who've been able to eliminate malaria based on existing tools and good use of data. Obviously, the higher burden countries in Africa, we know that even at the country level, not one size fits all for everywhere in the country. So there needs to be some tailoring of interventions, sometimes at a very local level, and particularly in areas that may be in a country that may be pushing towards elimination. So I was wondering if you had any examples of how localized data has led to local decision-making to tailor interventions to address the malaria burden based on that local context.
Okay, I think I can come in here. I don't know if it's allowed. Good morning, good afternoon, good evening, everyone. We've been able to actually put this to practice to play in Nigeria, once again mentioning Nigeria, because for instance, the seasonality is changing based on climate change. And working with the National Meteorological Center, we've been able to redesign the number of cycles for seasonal malaria chemo prevention from 3 to 4, and some locations are actually having 5 cycles of SMC deployments. We've also seen a situation where we've also used this data to stratify intervention mix. What I mean by stratification, yes, case management diagnosis remains the same everywhere, but the deployment of nets, there are some locations that are being classified as urban malaria locations and those that are rural, and interventions deployed to these areas are slightly different. We've also have a situation where we don't just use the malaria data to determine what's the interventions that we are running. We work with a lot of data. We triangulate data from different sources. We use immunization data for determining populations estimates. We equally use data from DHIS. You know, malaria also contributes to the DHIS data. And we have the National Malaria Data Repository, which Leah has talked about, which harmonizes both the routine data and the campaign data. So all of these are in localizing the use of data for decision making. It has helped a lot in addressing a lot of systems and a lot of situations as far as our country is concerned. Even in procurement and supply chain management, it comes in handy, where we don't just sit as malaria partners to carry out the quantification. Partners from departments and from other aspects, from different maybe HIV, TB, malaria, NTDs also make contributions to the procurement and supply chain quantification processes. So these are some ways where we've been able to share our data, make use of data from different sources to actually support the malaria intervention. Thank you, Anova.
Thanks, Inibasi. We only have a few more minutes for general questions. And again, I think we're in an exciting time in many ways. Again, we have a long way to go, but there are these new tools. People mentioned new vaccines. There will be new vector control tools that are in development, new drugs and diagnostics potentially. But one of the things which I'm sure most of you are involved in these days is this issue of artificial intelligence and how, as a potentially disruptive technology in both positive and negative ways. I'm just wondering if anyone has anything to say about how AI might be used in your area of expertise, or is it something, for example, Jean-Philbert, is it something that Africa CDC and others are now trying to think about how this might improve what we're trying to do, but also what some of the potential downsides are?
Well, I was sure this was going to come up, even if we are coming to the end. But I think malaria being a zoonotic disease by excellence, and really something that lends itself to the One Health approach, I think there is really an opportunity to sort of combine data from the human side to the environment side, and then the animal side. And I'm here in Nairobi, where they are battling an issue with floods, and I'm sure these floods mean that in the coming days we may see a peak in terms of malaria cases. So being able to use like weather information to predict rainfalls and then predict where the next potential hotspots of malaria cases is going to erupt and start taking the kind of measures. I think this is, I'm sure there could be people who are already working on this kind of applications. So really, really exciting to be able to leverage the use of AI to advance the intelligence with which we face malaria fights. But my colleagues may have a more targeted perspective.
Sure, Joangeline, do you have anything to add to that?
Yes, just a quick one on malaria surveillance and monitoring. In Nigeria, last year we had a pilot in one of the states, Kwara State, and as we know, AI algorithms can evaluate data, you know, from health records and certain images, etc. So we were working with one technical partner that they were able to use AI to help us with analysis of urban malaria in one of the state, on Kwara State, where we wanted to understand which possible urban district that we may not distribute nets during a mass campaign. We received a really good help from the Global Malaria Program. For you who know Dr. Bear, she's brilliant. So that's just one of the ways that we have seen it being used in malaria surveillance and monitoring.
I think there's lots of excitement in this space and lots of concerns as well. So I think the folks at PMI and partners are working to evaluate, you know, what that might mean and make sure that we're comfortable with what might come out of leaning more heavily on these technologies. I guess the one thing I just wanted to mention is I think there's a lot of room for sort of burden reduction, right? How can we make use of AI to write reports more quickly or do some more menial tasks that we aren't so concerned about what might come out of the AI, but free up time to spend doing other things? I think that's sort of an easy, quick win that I know many of our partners are looking into relying on more heavily.
Okay, well, thanks. I'm going to turn this over to Iniavasi to give some concluding comments. So over to you.
Thank you very much, Prof. Thank you very much, everyone, for having joined this very exciting session. I must say a few things first on the AI, because I know there's a pilot on the AI reader being deployed for RDT. I put something in the chat box there, and it's coming out very promising because it will actually help improve on the real-time reporting, the adherence to results, and even accountability. And it also helps to strengthen the public health system. Just as Leah said, there will be more time for the healthcare providers that are very few to also attend to other cases that may come to their facility. Now, going to the concluding part of this, I want to say we have excellent panelists up here. We've heard a lot about how data has been used and also how data can be used. How can we harness technology? Everyone is talking about AI now. That is the way everything is moving to. How can we harness this technology to the betterment of the fight against malaria? How we've seen how data has been used from conception stage up to the execution stage, and even at the point of recommendations. Data is also used in determining resource allocation. It is used in determining deployment of interventions. It is even used to showcase achievements, and is also used to showcase gaps. So using data in the fight against malaria is very key, is very critical. Like I usually tell people, data to action is more like a custom tailored suit. You know what the problem is and you get it resolved. So that the one size fits all, I think we've gone beyond that era. We should be using data now for targeted interventions. And I'm sure with the little we've seen over time, using data to address issues in public health and malaria inclusive, I'm sure we'll go a long way to actually make good use of this data, do good analysis. And data quality, I saw a question, data quality is very key to determining the extent to which we can use the data. So it also goes hand in hand. While we are talking about a data-driven interventions, what is the quality of the data that we are looking at? So strengthening data quality is very key. And I'm sure with a lot of things that is happening in the malaria space, this is gradually being addressed. So I will stop at this point and hand over to Bernard. Thank you very much, everyone, for having us.
Yeah, thanks. Well, first of all, thanks to everybody. There's some great comments and questions in the chat box that continue to come in. So I think this has precipitated a lot of discussion and thinking, which unfortunately we're running out of time, so we can't do it. But I hope that those, for example, there's questions on artemisinin resistance, how AI can be used to improve diagnostics, lots of different issues that have come up in the chat box. But I hope those in the chat box, I'll just offer our panelists as a resource. I hope you'll feel free to reach out to individual panelists for follow-up questions if you would like to do so. And again, I think for World Malaria Day, there was a time when there was not a World Malaria Day. Malaria was not, it didn't get the sort of interest that we all felt it needed. As actually the ministers of health and communities affected by malaria, primarily in Africa, who pushed this, which is why the Global Fund is the Global Fund to fight AIDS, TB, and malaria, and why there's a U.S. President's Malaria Initiative. And I know that organizations such as Management Sciences for Health and many others have been involved for decades in many countries, working with national programs to actually bend the curve against malaria. And even though we have, again, I think, as my colleagues on the panel know, when I hear that malaria stagnated or stalled, I think this has come up some today in the midst of real challenges like population growth, climate change, emerging drug resistance, definitely insecticide resistance. The fact that we've been able to not only hold the line, but continue to be prepared to push forward, I think is something we should celebrate here on World Malaria Day. So I'd really like to thank the panelists and colleagues from Management Sciences for Health for this rich conversation. I know that these are ongoing conversations among all of you, and I look forward to seeing where we are a year from now. So again, thanks everyone. And I guess it's Happy World Malaria Day. Thanks. Thanks, Jean-Philbert and Jean-Jeline and Leah and Inibasa and Ade.
Thank you all so much.
Thank you, Bernard.
Thank you. Bye-bye.
Thank you. Bye.
And thanks to all who joined.